afternoon, everyone. I'm Bridget Ryan, a faculty member here in family medicine, and Dr. Amanda Terry and I have the pleasure of having taught Kath and co-supervised her thesis, and I have the additional pleasure of welcoming her today. Kath is joining us to do her public lecture as part of her requirements for her Master of Clinical Science in Family Medicine. Dr. Stringer is originally from South Africa, but now makes her home in St. John's, Newfoundland, with her husband Mike, who is here with us today, and her two daughters. And she is a family physician in St. John's and is now also the chair of family medicine at Memorial University of Newfoundland. Kath obtained her medical degree from the University of Cape Town in 1994. She got her certification in the College of Family Physicians of Canada in 2004, and then her fellowship designation in 2016. Dr. Stringer has enjoyed many clinical experiences in rural and urban settings in both South Africa and in Newfoundland before becoming a faculty member at Memorial in 2009. Kath's areas of interest include the primary care of adults with developmental disabilities, as well as competency-based education for undergraduate medical students, and she developed that interest when she was the clerkship chair in the Faculty of Medicine at Memorial. So Kath, we welcome you to your public lecture, and I will turn the proceedings over to you.
Thanks very much, and thanks everybody for coming today. So as Bridget said, I'm here to give a presentation on my thesis, which is entitled The Primary Care of Adults with Severe and Profound Developmental Disabilities, the Patient-Physician Relationship. As a practicing physician, I'm fully aware of the benefits of teams, and I would just like to acknowledge that there was a large team involved in the success of completing this master's. So the outline of what I'm going to be chatting about today, I'm going to give some background information just to highlight the importance of this topic, go through some terms and definitions specific to this area of research, touch briefly on the existing literature related to this, and then focus on the methodology, findings, and discussion and conclusion of my research itself. So why is this topic important? An estimated 1 to 3% of the population live with developmental disabilities. In Canada, there's approximately 900,000 people. And some recent information out of Ontario, published in 2013, gives the number of people aged 18 to 64 living with developmental disabilities in Ontario at about 66,500, which was about 0.78% of the population. As we all know, deinstitutionalization began in Canada in about the 1990s. And basically this population was moved from institutions to now live and be cared for in the community as any other member of our communities. This population are now also living longer, which is good news. But as a result are accessing the adult healthcare system more often than they used to. And although a very positive move of deinstitutionalization with regards to acceptance and integration of these people into the community, significant health disparities still exist within this population. And while there's evidence of these health disparities across the world, again, recent quantitative data out of Ontario give us clear evidence of the higher rates of morbidity in this population, higher range of chronic disease. These people are also less likely to access preventative health care, more likely to be hospitalized for issues that really could be taken care of in the community, and less likely to have regular follow-up with their family doctors, despite them actually having most of their care given by family doctors. The therapeutic nature of the patient-physician relationship in family medicine is well accepted. And its importance is reflected in the Canadian Consensus Guidelines on the primary care of adults in developmental disabilities. Yet little is actually known of the development of this relationship in this population. So some terms and definitions which I thought I would review. Developmental disability itself. This is also known as intellectual disability in Canada, and also by other terms across the globe. For example, in the UK it's called learning disability. And what it entails is a person with significant limitations in intellectual functioning and adaptive functioning, and these are to have manifested by the age of 18 years. So what is adaptive functioning? Adaptive functioning is the collection of conceptual, for example, language skills, social skills, for example, interpersonal relationships, and practical skills, for example, decision making, that have been learned or performed by people in their everyday lives. Developmental disability is then further classified into the following levels: mild, moderate, severe, and profound. Knowing the expected range of abilities of one's patient is essential for future positive relationship development. My research focused on two of these levels, severe and profound. So people with severe developmental disability have an IQ of approximately 25 to 35 and have the adaptive functioning of a person without developmental disabilities of about age 3 to 6. So, for example, that would be having 1 to 2 word combinations with regards to language and being able to point to objects. Socially and practically, they are capable of understanding their immediate environment and immediate interactions in that immediate environment, but really considered not capable of any major decision making. A person with profound developmental disabilities would have an IQ of about 20 to 25, and their adaptive functioning is equivalent to a person from a newborn to about 3 years old. So conceptually, they're very limited. They may not be able to communicate verbally at all, or may be able to understand gesturing. Socially and practically, they're extremely limited in understanding their environment and would not be able to partake in decision making. So what does the existing literature tell us? While most of the research in this area the research in this area is starting to include both patients and caregivers, but most of the published literature is still from the perspective of healthcare professionals only. And no literature could be found focusing specifically on the patient-physician relationship in this population. Although the reference highlighted at the bottom there did refer to the development of the nature of the relationship in the findings, although the primary focus of the research was not the relationship itself. What the literature has highlighted to date is the barriers that both patients and physicians experience receiving or giving primary care within this population. It's also highlighted the importance and challenges of communicating with patients, and also the importance and challenge of incorporating the caregiver into this interaction. Another interesting thing is there definitely have been highlighted the lack of knowledge, experience, and confidence that family physicians feel treating this population. So, the purpose and design of my thesis. The purpose of my thesis was to describe the development of the patient-physician relationship between adult patients with severe and profound developmental disabilities and their family physicians. 2 qualitative studies were designed to meet this purpose. One involving patients and caregivers, and one involving family physicians. And this was fit primarily into the context of the Eastern Healthcare System, which is the system where I practice, and also drawing on family physicians from across Canada. So how did we do this? The methodology involved the use of constructivist grounded theory. Grounded theory focuses on developing a theory around a process over time, for which I was doing with regards to the relationship. Constructivist grounded theory highlights the active involvement of the researcher in the generation of the data. This methodology encourages the intimacy and reciprocity of the non-hierarchical relationship between the participant and the researcher, and really challenges the researcher to address any preconceived opinions that they may have. My involvement as a family physician treating patients with developmental disabilities really necessitated the use of this grounded theory, constructivist grounded theory methodology, and I think added to it. Sampling was designed to encourage maximum variation, ensuring the broadest range of information and perspectives on the topic. And with little research to date, I really needed to cast my net wide to discover the emerging perspectives. Study 1 involved caregivers that were recruited by family physicians in the community in St. John's and also who practiced at this local psychiatric hospital. And study 2 involved 3 groups of physicians. Firstly, family physicians at the St. John's Psychiatry Hospital. Secondly, community family physicians from St. John's and the surrounding Avalon Peninsula. And thirdly, family physicians from the CFPC, the College of Family Physicians Special Interest Group on Developmental Disabilities. I used the semi-structured interviews. The questions on that were developed from the research questions and revolved around the process of patient-physician relationship. Why does this relationship develop? How does it develop? And what is the trajectory of that relationship? Data analysis, the research team included myself and my two supervisors, Bridget and Amanda. And as per the constructivist grounded theory approach, the data analysis and data collection occurred simultaneously as part of an iterative approach to this data generation. And ethics was obtained from the local ethics board. So what were the findings of study 1? That was the study involving the caregivers. As you can see here, the 13 participants had a wide range of ages, relationship to the patients, formal training, and living situation. And this reflected the sampling approach to really encourage this maximum variation. The findings in study 1 revealed that the core process in relationship development from the perspective of the caregivers was that of protection. This process began out of a recognition of vulnerability of the patient. This quote describes the recognition of vulnerability and the resultant reaction of the caregiver to protect. But given that he is an adult now, he just looks like a little boy, and that's what he communicates to them. He communicates that I am very vulnerable right now, and I'm only little, so you've got to do whatever it is you've got to do to take care of me. This process of protection moved through a number of stages. Extreme nurturing describes the level of care that the caregivers felt they needed to provide for these patients in order for them to feel they'd been given the opportunity to maximize their potential. This took hours of intense care, one-on-one, and resulted in a very strong protective bond forming between the patient and the caregiver. The caregiver then saw themselves as entering and encountering this family physician together as one unit with the patient. And then depending on how their perceptions of this encounter went and how safe they felt, they then decided whether or not or how much they would open this bond to let the family physician in. And the result of this patient was this process was the creation of this patient-caregiver physician dynamic triangular interaction. This perspective of the dynamic triangular interaction reflects the importance of the patient-caregiver bond. And the caregiver saw themselves as interacting with the physician as one. So the physician actually interacted with this bond as one, as opposed to individually with each member. And they expected the physician to adjust in a kind of a dynamic way according to the needs of this unit and of the patient. And this interaction then formed the starting point for trajectories of relationships that followed. This diagram reflects those trajectories. On the horizontal axis at the top, you'll see time is depicted. And on the vertical axis here on the left-hand side, the dynamic triangular interaction is depicted. All the trajectories started at the same starting point. And this is when the patient and caregiver first interacted with the physician and decided, do I feel safe enough to open up this bond and let the physician in to form this dynamic triangular interaction? The top of the axis reflects those type of relationships where the patient and caregiver did feel safe enough to open up this bond and let the the physician into this interactive type of relationship where there was an equal balance of power and control within the relationship. At the bottom of the axis is those type of relationships where they did not feel that safety and they felt the need to keep the bond closed and actually isolate the physician as part of this process of protection and only let the physician in when they had to access essential medical care. After starting at the same starting point, these relationships followed these different trajectories according to the caregiver's perception of how this patient-centered triadic relationship developed or not. So trajectory 1, this upfront knowledge acquisition, this began instantly and actively and involved a family physician who either had a lot of experience in patients with developmental disabilities or at the very least had a good interest in having a patient with developmental disabilities. And they proactively gathered all the information they needed to really get a relationship going right from the start. The next one, familiarization with time. This was defined by the passage of time and continuity of care with one provider. And the knowledge and the familiarity that developed due to this repeated interactions with the family, with the caregiver and the patient themselves, resulted in a deep familiarity developing between the patient and the physician. This trajectory could not be hurried as this one was. It was the passage of time and these consecutive interactions that resulted in this deep knowledge and resulted in actually drawing the patient, the physician into being a part of the patient's family. And a number of participants actually used the word family. Trajectory 3, creation of a stable and functional resource. This describes a relationship where the caregiver took the lead role. And they involved the family physician, but really as a supportive but passive resource when they needed them. For example, when they needed medications adjusted or refilled. There was no need expressed to actually develop a personal relationship in between these times of medical need. The caregiver controlled when this bond was opened and closed, and they decided that. The sadness of this trajectory is, although the patient did receive good care, the added benefits of that personal therapeutic patient-physician relationship could not be accessed. Trajectory 4, assumption of the physician authority. This trajectory was followed when the physician assumed total control and left the caregiver feeling that their patient was not respected and not safe. And hence they decided not to open this bond and to isolate the physician and only open this bond when absolutely essential. The tension that this created damaged any possibility of a positive therapeutic patient-physician relationship developing. So, findings of study 2. This involved the family physicians. Again, you can see the study here. There were 15 participants, and they had a wide range of expertise and experience and training. And this reflected the approach to sampling to really maximize this approach. The findings in study 2 revealed that the core process in relationship development from the perspective of family physicians was that of acceptance. The acceptance was bidirectional. Involved in acceptance of the family by the family physicians of their patients as equals, as they would accept any other individuals worthy of their respect, attention, and empathy. In return, family physicians looked for signs of acceptance by their patients of them. And where not possible, they looked to the caregivers for encouragement in this process. These two quotes highlight the two aspects of acceptance. The first one highlights the acceptance of these patients as human beings despite their vulnerability. Part of that relationship is an attitude towards what I would call just human vulnerability, and that's okay. The second one highlights the challenge of recognizing cues of acceptance from the patients. It's been harder to get to know these people because you don't have some of the normal cues. This process of acceptance required the family physicians to do two things. One, they needed to commit to adapt to the patient's level of ability. And two, they had to define their relationship and their role in it. Family physicians had to adapt in many ways. For example, sometimes they had to adapt with regards to the venue of where they saw the patients. But he won't come into the room because he'll feel, threatened by that. So you adapt. As I mentioned, this process of adaptation was multifactorial and involved adapting numerous things, two of which include these. The first quote there describes how they had to adjust the amount of time that they spent with patients. Sometimes we just need to give them more time so that they can answer in their way they know how. They also had to adapt their communication styles, making sure that they still respected their patients. So you have to use language that they comprehend, but you still have to have an approach that gives them the respect of being an adult. The second part of the process of acceptance required the family physician to define their role in the relationship. As these relationships were complex, this was not always straightforward. As can be seen in this quote, part of the difficulty in looking after this group of people for me is figuring out what the role is. Understanding the nature of relationships has been the subject of discussion of philosophers and psychoanalysts for many years. And the family physician's reflections on the relationship with their patients with severe and profound developmental disabilities reflect to some degree their own personal philosophical outlook on this. The relative lack of interpretable feedback from patients in these relationships was a challenge for some family physicians who doubted the relationship even actually existed. For example, the first quote, "It's been difficult for me to develop a relationship or feel like I had a really knowledgeable, close relationship with patients in this particular group." Whilst others accepted the relationship independent of any of this feedback, such as in quote 2. There's this kind of sense of mutuality and so on. I guess it does depend on how severe the disability is, but I would say that as long as people are conscious, there's a connection. Regardless of the type of relationship family physicians were able to appreciate between themselves and their patients, this study highlighted the family physicians' acceptance of their patients' humanity and hence their right to some form of relationship. The patient-caregiver-physician dynamic triangular interaction, as perceived by the family physicians, appreciated the significant role of the caregiver, but also valued the primacy of the patient-physician relationship within this triadic interaction. So this to them was very important. And they felt that the caregiver interacted with this primary relationship. This was slightly different to the caregiver's point of view, where they noted the primacy of the caregiver-patient relationship within the same interaction. So integrating the findings of the two studies, this study is about relationships, and hence the importance of studying all the parties involved in the relationship. Study 1 included patients and caregivers by including caregivers who had a really close and enduring relationship and knew their patients well. And study 2 included a wide range of family physicians, all with experience in these relationships. As I said before, the main process behind relationship development in study 1 was that of protection, and study 2 was that of acceptance. And a previous study has alluded to the possible different perspectives of the patients and the physicians about these relationships. And in order for a relationship to work, all parties need to have an understanding of the other's process. Both studies recognize the vulnerability of the patient. The processes of protection and acceptance reflect the different reactions to this vulnerability. Each party needs to be aware of the other's process in order to understand their starting point. Family physicians need to be aware of the importance of the patient-caregiver bond and realize that early attempts to develop a patient-physician relationship independent of that bond may be seen as a threat, and hence a threat to the safety of that patient. So developing a safe place for the relationship to grow and focusing on developing trust between both the patient and the caregiver would therefore be essential first steps. Caregivers need to be aware that family physicians need to form a relationship with their patient, one in which they accept and get to know their patient as an individual human being. Supporting and allowing the patient and the family physician to do this would help in developing trust between the patient and the physician, and hence improve the therapeutic nature of that relationship in the end. Despite the differing processes, the patient was central, valued, respected, recognized as deserving of an equal and ethical standard of care, and recognized as deserving an involvement in a personal relationship by both parties. And knowing that everyone's on the same page to start with would assist in relationship development as well. Each study recognized the value of all three parties, and the involvement of the patient is central. The complexity of this relationship, however, dictates that defining each other's roles in this relationship would help in further relationship development. Each study recognized the importance of continuity of care and the positive impact on relationship development. Each study also recognized the extremes of need. Study 1, the extreme measures that caregivers needed to go to access what they felt was appropriate level of care for their patients. And study 2, the family physicians recognized the need to really provide an exceptional level of patient-centered care to meet their patients' extreme needs. So as I mentioned earlier, research in this area is scant. In Newfoundland, we need to at least begin with some epidemiological studies, as have occurred in Ontario. We've already begun to collect some data for descriptive study on service provision to this population at present. And studying the health outcomes of the patient-physician relationship within this population would be just as important as we have done within the general population. As mentioned, before, family physicians feel ill-prepared to treat this population, and there's already a lot of work that has gone into curriculum development around there, so studying the effective implementation of this curriculum will be important in the future. And the direct result of my research will be a published guideline on relationship development specific to this population for family physicians. That is all I have to say, so thank you very much, and I invite your comments and questions.
So maybe time for a couple questions, and I'll just ask the examiners if you can hold your questions to the exam. We appreciate that.
Anybody? Judith.
Thanks, Kath. That was great. I'm very proud of you. Great work. When I think about future research, it probably wouldn't get to ethics, but I would be really curious to do almost an ethnographic study and look at, what happens in that room, and do your findings resonate with what you actually observe.
Mm-hmm.
So, an observation study of some kind.
Mm-hmm.
But I think because of the vulnerability, I think about that, and I think, but because of the vulnerability described in this population, that just might not be.
I think that's one of the difficulties in this population, and I've read, people are starting to write about this kind of more in an editorial way, about are we actually further increasing the vulnerability of this patient population by not making research easy and accessible within this population. So it's a really difficult ethical question as to are we increasing or decreasing the vulnerability and trying to help within this population. And so it is nice to see at least the number of research involving patients themselves has definitely increased in the last number of years. Focus is obviously mainly on patients with mild developmental disabilities, those who can participate. But it is a difficult question, and it does make research in this area a bit more difficult. Mm-hmm. Yeah. Steve.
Thanks very much for that, Kath. As you were speaking, you can't help but cast your own thoughts back to patients and the relationships that you've had with people with developmental disabilities. And I thought your comments on the caregiver were particularly important because really many physicians will respond depending on how the caregiver is interacting. Mm-hmm. There are some caregivers who allow family physicians to develop a relationship with the patient and sort of just sit there as guideposts, and then there are others that want to be a little bit controlling, mm-hmm. and you find you have to struggle a little bit to maintain that relationship with the patient because mm-hmm. the caregiver is constantly wanting your attention or wanting you to do X, Y, and Z. So mm-hmm. it's you have to be a bit flexible under those circumstances. So mm-hmm. I appreciate your painting that picture mm-hmm. from the two perspectives.
And I think understanding the reason behind it, because they are protecting their patient, can help us in that. And often these people have come to us after being through a health system that doesn't always necessarily support them. So they have had experiences that have been quite negative in the past, whether it be traumatic experiences in an emergency room or inpatient or with another family physician, whatever it may be. And so understanding that they come with that need to protect and trying to really make explicit one's provision of a safe environment may help, in that relationship. Yeah, but you're right. It is difficult. That tricky triadic relationships are difficult.
And if I could just make another comment, I've also seen this from the perspective of my work as a coroner when things don't go well. And one of the difficult transition points is when a person with developmental disabilities transitions from the pediatric age group to the adult age group.
Yep.
Suddenly, if they require hospitalization, suddenly they're in an adult ward.
Yep.
They don't receive the same attention by any
Yep.
means from the staff, the medical staff. And that communication is so important.
Yeah.
And that tends to be more comprehensive in the pediatric age group, less so when that first contact with the adult system function. I think if we could all try to remember that would help in those transitions.
Transitions definitely came out as a barrier with regards to relationship development in my research, and has come out, and there has been some work done on transition tools and advice about transition. I remember one quote, and I can't remember it verbatim, but the quote was from a caregiver who described the transition from pediatric to adult healthcare system for the patient she was caring for as one of the most excruciatingly painful experiences that she never wants anybody else to ever have to go through. So unfortunately it is not one that we're handling well at present. Yeah.